diagnosis and post-diagnostic management in 15 minutes, but I thought that was one challenge too far, even by my standards of rapid speaking. I mean, as a GP, I'm used to getting people out of the door in 10 minutes, but I couldn't quite fit it all into 15. So, I'm a part-time GP. I spend the rest of my time at university doing research into dementia care, and I've been doing it for many decades now. So it's somewhat some dismay that when I saw this report from the Alzheimer Society a few years ago now, that showed that 40% of people they'd surveyed didn't have access to local specialist services. It caused me some considerable concern. And actually, strangely, around the same time, I was noticing in my own practice, and my colleagues were commenting to me, that our own memory clinics were very much becoming a diagnosis and discharge service. And so we were getting increasing numbers of patients diagnosed with dementia, and often diagnosed accurately with dementia with a subtype diagnosis, but actually most of their care, once that diagnosis was made, was being handed back to primary care unless some crisis or urgent situation occurred. And of course, the issue for most of my colleagues in general practice, and I don't think many of them will mind me saying this, is that the vast majority have not received any training in dementia care in their training as GPs. GP education has changed very little, I think, in the many decades that I've been doing it. We still do lots of things routinely, but geriatrics and dementia care is not a core component of GP training. And yet it's a real shame, actually, because over the last decade, I've spent increasingly my time moving away from managing acute conditions, which a lot of my nurses and nurse practitioner colleagues in the practice do now, to managing long-term illnesses, with an increasing shift from secondary care. Most of the diabetics in my practice, most of the people with heart failure, with high blood pressure, with asthma, are cared for largely by myself and my colleagues in primary care with the aid of specialist nurses. And this is taken from a paper that Steve Eiliff and myself produced nearly a decade ago now, where we very much felt that GPs and primary care teams could play a bigger part in managing people with dementia. Not necessarily because they had the specialist knowledge, but because a lot of the core skills that they're trained to do in managing long-term illness, whether that's diabetes, depression or dementia, were core to the things that they were used to doing. So, we've already talked about assessing people prior to diagnosis and referring to secondary care, discussing the diagnosis when it's been made and the implications of that, providing information or access and signposting to specialist sources of information, supporting families who are often actually patients in the practice as well as the person with dementia, planning ahead, increasingly these days looking after a person's physical health. Most of my patients on my dementia register have many comorbidities and require not just mental health care, but care of and coordination of their physical health. And increasingly providing care towards the end of life. 2/3 of people with dementia will die in the community, whether in care homes or in their own homes. All of that healthcare will be provided largely by GPs and community nurses and care home staff. So most of these skills are already present in GPs. What we need to do is either top up their dementia knowledge or ensure they're supported with help from people who do know about dementia. And actually, this concept is something that's been gaining momentum internationally. This is taken from the Alzheimer's Disease International report a couple of years ago, which showed that increasing numbers of people with dementia, not just in Western countries, but in lower middle income countries. And for example, in Tanzania, where I was working a couple of months ago, there are 4 neurologists in the whole country. Their option is not to develop more specialists in dementia care. There's no way they can do that. So what they have to do is look at the generalist physicians and nurses and field workers who they have greater numbers for and skill up that workforce to provide the care. It's a no-brainer in many low-middle income countries. Unfortunately, as I said, it'll be interesting to see what James has to say about skilling up the workforce. I don't think, in terms of raising professional awareness, we've done a particularly good job. We've certainly done it well with the public over the last decade, but I'm not sure how much we've moved on professionally. And the Alzheimer Society awarded myself and my team in Newcastle nearly 2 million last year to look at how we can improve post-diagnostic care for people with dementia, and look at what the effective components were and how we can develop more efficient, sustained pathways for delivery within our NHS and social care systems. We're only 9 months into that grant, but increasingly the evidence that we're picking up is that it's very fragile and fragmented, and that geographical inequalities in post-diagnostic care appear to be increasing rather than decreasing. So, interestingly, NICE developed some new dementia guidelines last year, over a decade after the initial ones. And what I think I can do while we're waiting for the results of our grant is give some tips as to how we could improve the primary care management of dementia from evidence and some good practice that is already out there now. NICE recommends a named health and social care coordinator. They don't say who this should be, but they do say it should preferably be a clinical or social care professional, somebody who is used to working independently and coordinating care in the community. That's not to say that there isn't a role for dementia advisors, but this is very much about somebody who can look at the medical and the clinical coordinating care, not just provide information. This may be a GP, it may be an Admiral nurse, it may be a community mental health worker, but certainly what we've started to do in my practice is make sure that every patient with dementia has a lead GP. We'd already done this for people with cancer for the last 5 years, so why not do it for people with dementia? It can be me, because I'm the dementia lead in the practice, but where possible, I'm increasingly asking my colleagues for it to be the usual GP, so the person they know best, and I then provide support and increased education to help them manage the patient. Information provision, very important. All of my colleagues in our big surgery have one of these guides on their desk for someone who's just been diagnosed to hand out, and only recently in the northeast, we've been very slow to this, have we got Admiral nurses. But we've also got a local dementia centre which just opened last year, and we're increasingly bringing all of those services together to provide a more coordinated approach once a diagnosis is being made. The GOVCONNECT service that was mentioned this morning by the Alzheimer Society will also be a very useful source for people. Increasingly, the NICE guidelines say that in primary care we should be more involved in the drug management of people with dementia, should they qualify for a course of dementia drugs. We can now issue scripts in primary care. We couldn't before, that the medications had to be started by a secondary care colleague. And so I'm hoping that if we can skill up my colleagues in primary care, they'll become more confident in actually not just monitoring these tablets, but actually prescribing them if indicated by a specialist colleague. One of the things I'm particularly hot on is getting people with dementia, when they have the ability to communicate still and to make decisions, to talk to me about what they want in the future. Hopefully, this conversation has been started by my memory clinic colleagues, and many of my patients say that power of attorney and issues like that are mentioned to them when they've been in the memory clinic. But a lot of people don't want to make formal legal documents. Some do, and it's very useful to have a power of attorney and to know whether that's power of attorney for finance or for health and well-being. But equally, if they're not keen to do that, I've actually developed a simple tip of actually asking them, should they become very unwell and unable to tell me what they want, who is the one person they would like me to speak to, who they would trust in terms of doing what they think would be best for their health. And with their agreement, I put the name of that person on their records. That helps when they lose capacity, or if they're ill with delirium or communication problems, to know who the named best interest decision maker might be within the family. It's a simple task, but it's very useful. Also, if a next of kin lives miles away, get their mobile phone numbers. So again, we can communicate with them, with the person with dementia's consent, of course. All of these things are very useful tips that are easy to do and quick to do, but aid our coordination of care in primary care. This is a very big one for me increasingly and for my GP colleagues. It's not just about dementia. Most of our dementia patients are aged 75 and over. Many are frail and in care homes. Dementia plus physical illness is the common, and often the physical illness might be more important than the actual mental illness. This is something that was introduced in primary care many years ago now, but it's something that I think we've underutilised, and actually just through lack of time and resource. We're meant as GPs to give all our patients with dementia an annual review. This can be actually a very comprehensive and very useful process if it was actually done in a structured and formal way. For many of us it's not, because we're not actually given any guidance how to do it, and we're not actually paid to do it. Compare our learning disabilities system, which is actually very different. This could make a big difference if we just actually formalised this and supported our colleagues to do this. That's, if you like, my tip, and I can pretty much get through that in about 15 to 20 minutes with practice. And obviously you don't have to do it all at once. You can bring people back and you can continue discussions. Driving in dementia, a very difficult area, but increasingly I think the role of the GP. Some great guidance came from my colleagues at Newcastle University, which I've put up there. I'm not going to go into it in detail, but that gives a very a neat algorithm, a neat pathway to follow if, as a clinician, you want advice on how to do this. Behavioural issues, I'm not going to dwell on. I think one of the great things that we've managed to do in the last few years in this country is reduce prescribing of antipsychotic drugs and improve the management of behavioural problems in dementia by using non-drug and behavioural and environmental approaches. There is some great guidance available, and I've certainly, I think most of my GP colleagues are now, I think nationally, it's been reduced by about 50%, I think, antipsychotic prescribing over the last 5 years. So we are getting the message across. And of course, a big one, I think, where we really do have benefits is that most of the spouses of people with dementia on my dementia register are my patients too. I know these people, I know them very well. It means I can see them independently. I can look after their physical and mental health, and I can provide support and advice to them. Interestingly, I just want to flag up this. We've just finished a very large program, 5-year program grant on end of life in dementia. And what we found in that is that not only families, but certainly professionals in the community were very ignorant and frightened about managing advanced dementia. And this is a new massive online learning course that we released from Newcastle University on how to care for people with advanced dementia as the illness progresses. It was made for family carers, but actually of the 1,500 people who completed the course in March from 101 countries, we found that 50% of those are healthcare professionals. So it's obviously relevant for clinical and care professionals as well. And finally, we've heard a lot about technology today. I think it's useful. I often bring up this website with families in my consultation, which lists a whole variety of assistive technologies that are currently available, and it's a very useful thing to do whether you're in a nursing home or you're a social worker or a GP. I won't dwell on the effectiveness, but I think it has a place. But at the end of the day, there's a lot to be said for personal and continuing care, and that's what I think we really need to be doing more of if we get an efficient way of delivering it. I think I'll stop there.